Are you going to punish
For what?
What? What about him? Yeah, after the lecture.
after 73 year old grandma?
Okay. We're going to go through diseases, which, you know, this one will be tricky to use your book for sure. All of the information that I have in here, the book is still the resource. The problem is I basically just went through and cherry-picked all of these different disease processes, some of them that we have talked about in the past, but really kind of need a little refresher right before we go into the World and Registry. And so I kind of just list, like, I got a lot of this from Patho, some from the human body, neither chapters that we even went over specifically, and then a decent amount from 16 as well. But the truth is I just brainstormed a bunch of different disease processes and was like, hey, what's something that if it pops up, we want to be able to hit that out of the park on the registries, right? So things like Lou Gehrig's and MS and stuff like that they kind of love to just splice in, right? So this could be one of those chapters where it's a ton of work, honestly, and a bunch of different memorization stuff, and it's probably unlikely that the registry is going to be full of it, and it's unlikely that you're going to run a series of calls from conditions that are described here in many ways, but it can be super helpful trying to differentiate it. So my hope is to largely simplify a lot of these kind of ambiguous and nebulous concepts and diseases down to their core. Now, we've got a bunch of different terminology to go through for sure. And I think that's going to be the way that we kind of build up the lecture towards neuro and get through it. What's the difference between physiological and pathophysiological? What does that mean? That's so funny. Right before I said it, I thought, why am I wasting time on this? Well, I'm glad I asked. One of those is normal. One of those is disease. Physiological processes are normal processes. The way your heart beats, the way your air diffuses across into your lungs, those are physiological processes, and we call them pathological when they're diseases, right? When something is wrong with that process. So is a heart attack physiological or pathophysiological? Yeah, you're on. What does it mean to be communicable versus non-communicable? Yeah, transmittable is, I think, how I would do it, though some of that language slices super thin there. Like one of them referring only to a human, all kinds of different stuff. So now it's important to know that autoimmune is basically your body attacking itself. That's what autoimmune means, right? And so there's a couple of diseases we're going to talk about that are literally autoimmune, and then there are some that I'm going to tell you are autoimmune and then aren't, but that's just because it would be like me saying that the only antibody is IgE, and you could go probably your entire career without realizing that wasn't true, but it was always what you encountered and it was always helpful. So there's some of that stuff that we're going to talk about there. Infectious isn't self-attack, it's something else attacking you, attacking your cells. It's a living organism. That's what infectious means, right? So stuff like heart attack is pathology, but it's not autoimmune and it's not infectious. Inflammation follows infection. What follows the inflammation? Fever, as your body fights and struggles. Sepsis and all those things, we'll talk about as well. We're also going to talk about some degenerative diseases, just wear and tear, right? Things like our osteo issues, largely. But there's a whole host of different descriptions and terms. We talked about iatrogenic previously, meaning when we did something, the medical professional did something to harm them, right, in a sense? Or I shouldn't say when the medical professional did something to harm them, literally the treatment harmed them, right? Now, congenital means you were born with this thing. Genetic means literally the coding of your DNA. Can anybody think of a congenital defect that isn't specifically genetics?
Like an STI, something like that, someone born.
Yeah, okay, like mom has an STI, so baby has it now. Okay, that was great, yeah.
Cystic fibrosis?
Is genetic. Alanis?
Can you say that one again? The treatment part?
Say which one, the bottom one?
Yeah.
Iatro?
Cool, thank you.
Yeah, cleft palate, hypoxic brain injury. Like, so you can have, I bring this up because I see the term kind of thrown around a lot on testing, congenital. And what it means is that you're born with it, but not necessarily that it's your genes, right? If mom is drinking alcohol and you're born with deficit, it's not a gene disorder, but it is congenital, right? Nosocomial means hospital acquired. What's a very common nosocomial infection? MRSA for sure. Good job. We're going to talk about some arthritic diseases and how to kind of differentiate them, both osteoarthritis and rheumatoid arthritis. To put pretty simply, rheumatoid arthritis is more of a global systemic experience. Now, just a quick anatomy discussion about how our joints connect. Basically, we've got two bones, and those bones are protected by largely two things there. We've got cartilage that works like a cushion, and even though this shows it like they're not connecting, they do connect. They push against each other. It's also padded by the synovial fluid in the synovial membrane. So there's something called the Ig Nobel Prize, which is like people winning an award for weird science. And some guy, essentially, he like cracked only his left hand for like 25 years and proved essentially that, see, it doesn't cause an issue, like, so he won an Ig Nobel Prize. But they say sometimes that that crack sound, who like has to crack their knuckles now that I'm talking about it, is putting increased pressure on those joints, which is forcing that synovial fluid to boil, and that's the pop you hear.
They say that because that's why have like this liquid, and when you
I don't know.
drop it, it's because of the liquid. So they say that because it's supposed to be like doing damage to the liquid.
Nah. Now, with osteoarthritis, this is specifically the joint cartilage breakdown, right? This isn't your bone, so to speak. It's not the synovial fluid. This is the joint cartilage itself breaking down, and it can happen over normal wear and tear. What kind of disease do we call that? Not iatrogenic. Degenerative, right? Nobody should be surprised to hear that this largely affects people on a longer timeline, right? Now, osteoarthritis can come with joint pain and swelling in the fingers. I just wanted to point out that it won't look like this. This is called clubbing. This is basically where like your fingers are like lollipops, right? They just get broader at the end. Does anybody remember what causes that? Yeah. CHF can. Emphysema, because both, you can get clubbing fingers from emphysema or COPD and CHF, because in both states you're chronically hypoxic, right? Now, I've seen a million chronically hypoxic people, and I've never seen clubbing fingers in the field. So I don't know how common or specific it is or how late stage it is, but I have seen it in testing for sure. If your patient presents with clubbed fingers, we know they live chronically with hypoxia. So again, osteoarthritis, joint cartilage breakdown, it's causing inflammation. It differs from osteopenia. Osteoarthritis is the literal joint cartilage breaking down. Osteopenia is just the density of your bone breaking down. What that means is, put pretty simply, we all get osteopenia, we don't all get osteoporosis, right? When the older you get, the more brittle your bones will get because they will become less dense. But we won't call it the pathological osteoporosis. There's a couple of different things they have to measure. But the point is this: all of our bones are becoming more brittle, but they're not always this pathological severe condition called osteoporosis. So we could ask some specific anatomy questions differentiating these things, but if I said a question like, you're a 65-year-old male has fallen down the stairs and fractured his right leg, which of the following do you think is the most likely that he has? Osteoarthritis, penia, or porosis? He broke his leg, he's 65. Which of the three should you most likely suspect? Porosis, she says. osteopenia because everyone's got it, right? I mean, well, if he broke his leg, not that I have a question like that necessarily, but it's if he broke his leg, osteoporosis is going to contribute to that fracture way more because it's far less dense. Yeah.
There's a picture in the audio, and if you have less bone density, are you able to hold more fluid in the bones, or?
Don't know. Never thought about that. Probably, but the whole point of getting it into the bone is that it's absorbed into your vascular space in the first place. So whether or not, because you have osteoporosis and you can store this much and I don't, so I can store this much, within a minute, it's all zero anyways because it goes intravascular. So, but I don't know.
Okay.
Probably, right? So this picture kind of more demonstrates like these connecting joints and how much like a car without oil, right? Just that constant wear and tear is going to cause inflammation and damage that tissue. And don't forget, of course, that even though your bone is this solid, hard thing, it's still considered tissue, specifically connective, right? And it can get inflamed and cause a process. Now, I talked about osteoarthritis causing swollen joints. Do you see how different those fingers look? Okay, that is very strongly indicative of rheumatoid arthritis, which is a more severe situation for sure. Rheumatoid arthritis is not just the joint cartilage breaking down, it is also the little liquid balloon coating the area, the synovial joint, and therefore releasing the fluid. If you had to choose between osteoarthritis and rheumatoid arthritis, which one do you choose? By a mile. not the Gollum hand or whatever. Help you with a strong hand? Yeah, that one's not great. Now, not only is it an autoimmune disorder, it also has some genetic environmental components or contributors. The big thing about this is that rheumatoid arthritis is systemic, right? Like osteoarthritis, if maybe you have a couple of joints that you're using more often than not, right? Like let's say you always use your zipper with your right hand, so therefore your right hand specifically. Okay, but it may not necessarily be bilateral. Whereas rheumatoid arthritis is a systemic condition, that one was tough for me to get through, is a systemic condition, and therefore we would experience bilateral problems, right? Often visible in the hands, quite simply just because they're small. Now, this can often be confused for Lyme disease. If you go to the registry and they're asking questions about differentiating rheumatoid arthritis and stuff, Lyme disease is sometimes thrown on there as well, because again, Lyme disease is systemic and so is rheumatoid arthritis. The presentations are going to be what you get through. You know, you got somebody with an isolated hand pain, and generally speaking, nobody is just waking up with osteoarthritis. They know what it is, right? And they'll tell you so. I don't expect you to know anything on here. I know only a portion of it, that's for sure. This is just basically my reminder in case I forget to emphasize the systemic nature of the pathology of rheumatoid arthritis. Again, what does autoimmune mean? That's right. Your body has an autoimmune, if you have rheumatoid arthritis, your body is attacking its own synovial joints, right? Not fun. Now, Lyme disease also affects the joints, and it's a systemic inflammation, just like, well, I guess I should say similar to rheumatoid arthritis. And you get it largely from a tick bite. If you get bit by a tick and you get a bullseye rash, does that mean that you now have a meat allergy?
It's only a certain kind, right?
Yeah, I just bring it up because most people are like, oh no, I got bit. Nah, I don't know about most, but some people are like, I got bit by a tick. That means I'm going to get the meat allergy. But that's a very specific tick, if you remember that from environmental. Right? So the big danger here is a tick bites an infected creature, then it bites you, the tick, then you get Lyme disease, right? But it's the Lone Star tick that's going to give you the meat allergy. Now, what's interesting with Lyme disease is because, again, it's systemic, it can come with all kinds of different widespread issues, right? Fever, chills, headache, fatigue, facial palsy, irregular heartbeat, dizziness. I mean, sky's the limit, right? Because essentially it's just casting this inflammatory process all across your body. Now, if we go in and we get a patient with isolated facial droop, I don't want you to click Lyme disease as the answer, right? Even though it can cause a trigeminal nerve issue, even though, if it ever helps you, I don't know, there's a whole list of different cranial nerves, and the trigeminal nerve is here, 1, 2, 3, like a little crow, goes across your face. But once somebody just made that 3 fingers and put it on their face, I never forgot where the trigeminal nerve is. Some of them are a little easier for me, like optic nerve. Does anybody know what the optic nerve, cranial nerve number is? 2. You know how I remember that? That's right. No, because I'm very smart. Anyways. Now, you can get a bullseye's rash, or I guess to finish the point on it, if you've got a patient with unilateral facial droop, I want you to think stroke first and foremost. However, if it starts saying things like, there he was, you're responding to a campsite, patient complains of a rash, doesn't even mention the bullseye, just says it, okay, now I'm starting to suspect we got a issue with Lyme disease and therefore Bell's palsy, which is of course that facial droop that isn't a stroke. Why would I get widespread aches and pains with a Lyme disease? Because it's systemic. Just trying to get you to say it.
You know, the other thing that kind of helped to rule out a stroke in mechanicus?
Yeah.
Is the time.
Yeah, sure. Yeah.
Having facial droop for 4 days.
That is an excellent point.
As long as it's
Yeah. You either had a stroke and are never coming back fully, or you're not having one currently. Yeah, I like that. Let's see. Oh, and then Rocky Mountain spotted fever. Part of this is we kind of just touched on it real quick, and I just touched on it real quick again, because no, I don't think you're going to get a slew of these questions on the registry, but if you got one, I want to make sure it's somewhat fresh in your mind. With this, again, another systemic inflammation issue. This one will cause a literal degradation of your blood vessels, which can be a major, major problem. Blood vessel degradation. Now you're starting to experiencing paralysis as those nerves are innervated. If that happens in your heart, it can cause all kinds of major, major issues. With the Rocky Mountain spotted fever, we're experiencing more of this petechia-like pinpoint rash, not the bullseye, not blisters, a very specific kind of rash. That is the sign that that vasculature is being destroyed and breaking down, and now they're leaking into their skin. Now, gout is interesting. If I had to summarize what I want you to know about gout in just a quick phrase, I would say usually the big toe, uric acid crystals. That's gout in a nutshell. Now, you can get gout from all kinds of different things. It can form from a bunch of different reasons. You could have too much urea, you could have too much uric acid, you could not excrete it as much as you might need to. There's even issues with having too high salt diets that are causing it, and all kinds of different issues. Now, I don't remember why it usually affects the big toe. The only thing that I can think of is because, quite simply, all of your fluid shifts down. And if you've got too much uric acid, then it's going to coalesce there in your lower extremities and in the biggest joint that appears. I don't remember, other than if you said, oh, my aunt has gout. I'm like, does her toe hurt? And you were like, whoa, how'd you know what was happening there? I'm like, because it's always down there.
What's uric acid? Isn't that part of the, oh my gosh, what is it, excretory system?
Yeah, urine. Yeah, it's a byproduct of the breakdown in various forms of that.
Why is it all the way down the feet and knees?
Just because that's where it's settling and it's harder to return. You can get gout in any joint, but you usually get it in your big toe, or at least in the feet. Now, don't mistake essentially the fact that if we've got a buildup of like, ooh, that's not good for my joint. I'm like, okay, yeah, but if you're having fluid settle in the area where the uric acid is not being pulled back and then excreted appropriately, you're probably also having fluid buildup there, like creating an internal trench foot, if you will, right? Another common place is to get gout is in the knees, another big joint that's still low and therefore more difficult to kind of return it and then excrete it. One of the biggest, most important things though is the unilateral experience, right? Whether it was in his hand or whether or not it was in his feet, the fact that it's one-sided is really helpful for getting us to think gout and not what? That's okay, we'll talk about it a little bit more in a second. Now, naturally, if you're having an issue where you're not properly excreting things and you're starting to get uric acid buildup, that same excretion issue is going to lead you to having things like renal calculi or kidney stones, right? If we're getting this buildup in our joints, a person has gout and now today they have back pain, we're like, oh, okay, this is an easy line to draw. You're not excreting uric acid, that's why you have gout, or at least as much as you should. It's reasonable to think that other things are building up elsewhere. So kind of as a summary, if your patient has swollen joints in the hands or in the fingers, I'm definitely going to think rheumatoid arthritis, especially if it's bilateral, right? If you've got it in the feet or the toes, I'm going straight down that answer sheet looking for gout and then bummed when I don't find it. Even though gout can affect the knees for sure, osteoarthritis is often where we're going to see it in the hips and, osteoarthritis we're going to see in the hips and the knees because those are super common moving joints that are broken down over by degenerative diseases over time. Where we'll see osteoporosis poke his head, if not in the hips, and then simple fractures, is just generally the breakdown in the spine causing something that called kyphosis, which I think we'll talk more about in neuro. Cool. This is part of the reason I didn't want to give out the slides. I didn't want you to be able to skip to the next one and just chatter. So we'll pair off, and I just want you to work on this, essentially, together. Like, hey, what would I expect rheumatoid arthritis to present, or where would I expect it to present? Why is it happening? And what are some distinguishing things of that might get me to think one or the other? Almeida, Alanis, boom, boom.
Yeah, and then gout is uric buildup of uric acid somewhere. Yeah. That's kind of what
Jack, what do you know about gout? Where's that?
It's typically in the feet or toes.
Somewhere below the waist.
Typically
Yep.
toes.
I like it. Where would you think maybe rheumatoid arthritis?
Rheumatoid, fingers and hands.
Love it. What's happening that causes gout?
Gout is fluid mixed with uric acid.
Yeah, uric acid crystals building up.
So does fluid have anything to do with it? Or is
I don't
the
think
uric
so.
acid-
It's the acid itself, yeah. And then rheumatoid arthritis, what kind of disease is that?
Systemic inflammation.
Yeah.
Systemic inflammation.
Dude, a million things cause the systemic inflammation, specifically for this, is autoimmune issues. It's your body just chewing itself up because its genes are dumb. Cool.
Are you gonna be there for MC hours?
I guess so. Yeah. Oh, you know what I should do? I should pause during this. Alrighty, gang. Pam, what do you think? I only ask you because I never heard your voice, that's all. Sure, where's it at? Small joints? If I had to say hands, feet, knees, back. Yeah, totally. All those things. Well, you wouldn't be wrong. You can get it in all those things. Alex, where would I primarily expect to see it?
I was gonna, like, I don't know if this is what you're looking for, but where would I would see, like, systemic, like, your...
Sure, yeah, and that's why you could see it in all those
all
joints.
the joints. I mean, that's not really intensive.
No, that's okay though. Alanis? Right. Ultimately, where I'm looking for, yes, you can get it everywhere because it's systemic, but I would expect to see it in the hands and the wrists, right? More to the point. The big thing, because it's systemic, is knowing that it's a bilateral experience, right? That you're not just going to get it one place. You're probably going to get it crop up on both sides because it's your whole system. So if I said your patient has, an isolated left index finger that's swollen, red, inflamed, and is hurt for a couple of days, and there's no trauma there, well, if there's no bite or cut, and I don't think infection, now I'm starting to think rheumatoid arthritis or osteoarthritis, but not gout. Sorry. All the way around. Gout or osteoarthritis, not rheumatoid arthritis, because it's unilateral, not bilateral.
I think I lost myself when you were explaining this. On gout, why? How you get that? Like uric acid crystal?
Put pretty simply, with decreased kidney function or when you have excretion issues, you're not getting out the byproducts and breakdown enough, you'll have a buildup of things you don't want. And if it collects in your joints, that's a problem. And so gout is the condition, or the label we give a condition, where you're having trouble in your kidneys and the like excreting uric acid.
I would guess if we had gout, you would expect having more stuff going on too, right?
Not necessarily. I mean, they often have kidney problems for sure, but not necessarily. Gout could be the biggest one.
Oh, thank you.
Yeah. Now, there's a lot of commonality here, joint inflammation and all kinds of different issues. One's uric acid, the other's autoimmune. We're going to, again, expect swollen joints. You might even get, why would you maybe get fatigue with rheumatoid arthritis, but not necessarily with gout? Because it's an autoimmune and it's systemic.
Would the sudden onset for gout also be a key sign?
Sudden onset, yeah, sure, yeah. Yeah, where's the rheumatoid arthritis going to build up? Yeah, I like that. Now we're going to talk a little bit about some bowel stuff. Big bowl. Ulcerative colitis. Ulcerative colitis is basically we're trying to build a map here to differentiate Crohn's and ulcerative colitis because those are often confused one for the other. With ulcerative colitis, one of the most important things to realize is that it's not technically autoimmune. I'm not going to ask you some weird trick question about that differentiation. It's good enough to remember that it's autoimmune, even if it's just an overactive immune technically and not autoimmune. Basically what happens is the area in your gastric system that isn't your mouth and is exposed to the world starts having bacterial issues, right? And so if you've got feces coming out and you've got all kinds of different contributions to your gastric system around your rectum and your body overreacts to that, it can cause ulcerative colitis. Then it will start marching up your colon, right? And so it's essentially going from end to end in reverse, ulcerative colitis. Yeah.
Is this the one that's usually only pain on the left side because it's the descending colon?
Yep. So one of the things we don't talk a ton about in abdominal, just because we're talking about so much other things, is the left lower quadrant abdominal pain, which if it's not an ovary, the only thing else that's over there is the descending colon largely. And so that's going to make me think ulcerative colitis.
So left lower?
Left lower. Because essentially your large intestine is just going up, over, and then down as it goes out your rectum, right? And so essentially lower left abdominal pain is strongly indicative of, if not a bowel obstruction, ulcerative colitis. Now it's superficial, and I guess what I mean by that is not like on your skin. I just mean that the lining is what's being damaged in your colon for ulcerative colitis. Consider ulcer colon, right? It's part of the reason, we'll talk about it here in just a second, about why it can change how the feces looks, and that's an important distinction as well. Now with ulcerative colitis, the important part is the pattern. The issue is that patients, real patients, will say things like, oh, my stomach hurts, and they mean abdomen, and they mean specifically lower left quadrant and upper left quadrant, or something like that, right? Now, unfortunately for them, they didn't go through AEMT school, so we got to do all that work for them, right? If I've got a person that's complaining of just general symmetrical pain on the left side, both lower and upper, in a sense, that's a bit of a good news for me, because I know that your colon goes up the left side. The big distinction I'm trying to look for now is this peritonitis or is this ulcerative colitis in that regard? Because I know it's not Crohn's if it's just this area, right? It's got a pattern that kind of follows the trail. There's no real gaps in it. And it's less important to remember that about ulcerative colitis so much as it is to remember that Crohn's does have gaps in the pain and complaints. Now, some of the signs and symptoms you'll see with ulcerative colitis, yes, typically this lower left quadrant abdominal pain where that descending colon is, but of course, if it depends how far it's gone, it can march up and go across as well. You'll get fevers and chills, essentially, as you start to experience a more systemic process of the inflammation. You may end up getting lots and lots of diarrhea, and most specifically, it may have pus, blood, or mucus in it. And I picked this picture up there because it's got that unforgettable green one to kind of help remind you that, look, as your lining breaks down because of the ulceration, your poop's going to get weird or weirder. Yeah.
Is this the one that has pockets?
No, that's diverticulosis.
Okay.
So would it traveling like up be like an early or late sign, or is there like a differential between?
I am pretty close. I don't have enough knowledge to actually say this, but it wouldn't surprise me at all if you were like, I'm actually an expert on the colon. And I was like, oh, congratulations. And you were like, it literally is 99% of the time just the lower left quadrant. I'm like, cool. I don't know that, but I know it can go all the way back. So the lower left quadrant, that's why I said, I think on abdominal day, I'm like, if you ever get a patient with lower left quadrant abdominal pain, it's like, yes, okay, not much is there. Does it have an ovary? No. Woohoo! I only know one thing that causes a pain there. Well, I guess two if you count obstruction. So the pus and the blood and the mucus, this is kind of like the same thing when we're going through urinary stuff. You're like, oh, okay, you've got vaginal pain. What's the pee like, right? If there's blood in it, discoloration, is there an odor? Because all of these things are going to get us to point in different directions, not the least of which, of course, would be their menstruation. Now, with Crohn's disease, this one's a little more distinguished. Crohn's disease is a chronic inflammation. We are not super sure what's causing it yet. It's what they call idiopathic. Now, unlike ulcerative colitis that is largely degrading the lining, causing the pus, this one goes deep into the intestinal wall, which thickens it and can cause all kinds of fat to build up around the outside, really distorting your gastric system. I say end to end here because it's the most polite way I can think of it, essentially, but it means any involvement, yes, any involvement with your gastric system. Again, it's not technically autoimmune, it's more specifically overactive immune. I'm not going to ask questions that gets you to know that. I don't super know the difference myself. But one thing I do know is the skip lesion pattern, right? If a person complains of isolated lower left quadrant abdominal pain, that's going to get me more in the ulcerative colitis wheelhouse. If they start talking about throat or upper GI or pain over here with those gaps, that's going to be an issue. If I got a guy that's like, oh, yeah, it hurts really bad down here, and I'm like, oh, okay, and I'm feeling around, I'm like, oh, yeah, it's isolated there. I'm like, cool, isolated ulcerative colitis, got it. And I start feeling around, I say, oh, actually, it hurts right there too. I'm like, okay, I don't think ulcerative colitis anymore because it should have hurt all along the colon because it's following a path, right? So again, this, as most abdominal things do, this puts us neatly into the go to the hospital, treat for pain and shock categories. Not that you necessarily should be spending 27 minutes on scene being like, wait. Yeah, Crohn's. Phew, got it, nailed it, right? And I've never had a patient that I suspected had Crohn's that didn't know they already had it. So one of the dead giveaways that should get us away from ulcerative colitis are things like right lower quadrant abdominal pain, which we're going to see almost never with ulcerative colitis. What else is in the right lower quadrant? Appendix. What else is in the right lower quadrant? Ovary. Right? And so simply getting the sex of the patient can help us look one way or the other. starting to ask questions about menstrual cycles one way or the other, looking for signs and symptoms like rebound tenderness, which is not going to necessarily be present with this. In fact, if I said your patient has Crohn's disease and is experiencing rebound tenderness in the lower right quadrant and the lower left quadrant, what do you think he has? He might have appendicitis, but there's a worser case scenario than appendicitis. Peritonitis, right? Peritonitis. Fatigue, as well as not, I almost want to say, not, you won't have bloody diarrhea, but in truth, it's just mild or very rare. But if you said, hey, this guy's got diarrhea and it's got weird stuff in it, I'm like, okay, ulcerative colitis, because we're watching the lining of his colon come out, right? You're like, well, can't Crohn's do that? I'm like, no, Crohn's isn't a series of ulcers along your intestines. It's more like the walls of your intestines struggling. It's a different experience. It's not going to lead to pussy diarrhea, and it's not going to lead to blood usually either. Right? The skipped lesions will definitely be the way through. Just be on the lookout, because it's not always described as skip lesions. It'll be more descriptive. Cool. You just have to learn diverticulitis on your own. Yep.
So do these happen hand in hand? Like you will have diverticulosis, but it becomes...
I don't know what the math on it is, but I would say that if I got diagnosed with diverticulosis today, I'm like, okay, I have to completely alter my lifestyle to avoid diverticulitis.
Okay.
Is it inevitable? My guess is probably, but I don't know. So, diverticulitis, they may not know that they have this, right? Or at least they may not know that they have diverticulosis. It's not like you get everyone's finding out that they got an issue long before it causes pain. Usually it's dietary issues with diverticulosis or mild and moderate symptoms. But with diverticulitis, that's where one of those pockets, or maybe far more, have gotten inflamed, and that's going to be a bad day for sure. What's that? In the colon? Yeah. Commonly, yeah. Which now puts us tragically back in the left lower quadrant again, but it's all colonic stuff.
So locis is just the pocket?
Yep.
The
Itis is the inflammation of it. Mm-hmm. Now, if you're keeping score here about blood and stool and pus in it, which you really should be, essentially, blood in the stool from diverticulitis is unlikely, meaning if I get a person with lower left quadrant abdominal pain, and they're feeling weak, and they're feeling dizzy, but their vital signs are okay, I'm going to ask them about their last bowel movement, their last out, yeah. All the phrases that come to mind are just not recordable phrases. Yeah, so exactly. And so they're like, I'm like, the big question is did it look normal? And if they say yes, and I'm like, okay, so that means it was not too loose, it wasn't floating, because sometimes normal for people is still pathological for us, right? Oh, I always have loose stools. Well, okay. So getting through that essentially is going to be found with the how it was contained. Now, peptic ulcers essentially are just stomach ulcers. Ulcerative colitis is an issue in the lining of your colon, whereas a peptic ulcer is an issue with the lining in your stomach. A major culprit to this is NSAID use. You know, you're an athlete using ibuprofen every day, which is inhibiting prostaglandin creation in your stomach, which is important for lining of your stomach, but it doesn't do that anymore because you're inhibiting it with NSAIDs. But the number one cause of it is a specific bacteria called H. pylori, Helicobacter pylori. If you see that word on there, H. pylori, you know a question on peptic ulcer is about to happen. Where you pick that up is from places that ain't got the FDA or whatnot controlling what's coming in and out of your mouth with food. Now, I say stomach here with an asterisk because you can get peptic ulcers in the beginnings of your small intestines as well. So it's not just stomach, but that's usually where it is. People will have gastric reflux disease. They'll have acid reflux issues. They'll go and get tested, and some doctor is going to say, oh, I wish you would have come with a piece of your own doo-doo in a cup because that would really save us some time. So they send you with a cup to go home with, or whatever the case is. You squat very awkwardly over the tiniest cup in the world. So I've heard. And then you bring it back to them after storing it in the freezer so it don't go bad. It's
In your food freezer?
no, in my specific rectum freezer. No. Because it has to keep. Yeah. Every time somebody comes over to my house for a popsicle, I'm like, not that freezer. That one's different. They're like, why do you keep putting sticks in them? All right. Now, we're going to get, where would you expect, if you had a patient with a peptic ulcer, where would you expect their pain to be? Lower left quadrant, lower right quadrant?
To be honest, tummy ache, like.
Yeah, tummy ache. And since the stomach largely is vertical in this sense and midline to left, we wouldn't necessarily expect it in the lower and far less on the right. We're getting vomit episodes and possibly nausea. In the epigastric, everyone point to their epigastric region real quick, right? It's very important we don't point at our partners because it's always up higher than you think. Like basically right where your sternum ends, think about the word epigastric, right? It's above the gastric, so it's way up there. We get calls for this all the time. Someone says, oh man, I got chest pain so bad. And you get in there and they're holding their epigastric region. Now, I don't know the mechanism behind, here's what I know. I've had plenty of people that had chest pain and it was epigastric and it was just acid reflux. They had a peptic ulcer and that was the problem, right? And that all makes sense to me. But I've also seen a bunch of people who were actively having heart attacks who had nausea and vomiting. And so it's a distinction that's important to be made.
Question.
So.
I remember with epigastric, it would change composition. Like they will be worse if they lay down.
So
They have it the same.
the only positional pain changes that I know largely are associated with pericarditis, which we get in, so with pericarditis specifically, it's the inflammation of your pericardium around your heart. And if you lean forward, it causes less pain because it's going to put less stress. So I don't know any like specific, I think we all learned or something, maybe in the study session downstairs, that pancreatitis is associated with some movement stuff, but I don't know that. Now, and to save time, basically, this is where you're going to see it in the field, and you might see it on test as well, trying to decide whether or not this person has isolated gastric reflux from maybe a peptic ulcer or are having an active heart attack, right? Now, a lot of these shared symptoms, this epigastric pain and nausea, vomiting, look, if you throw up enough, you're going to have a whole bunch of pain. It could make you weak and dizzy and diaphoretic. So if you had to pick, catastrophically thinking, which one should I suspect? Well, that's going to get me in the wheelhouse of, I'm going to think that these shared symptoms is a heart attack. But if it says something like, oh, well, they've just traveled from overseas, they, just came back from a trip from Mexico, now he's complaining of vomiting but no nausea. You see what I'm saying? I'm starting to get you more in the lines of thinking that it's acid reflux or peptic ulcer, not that it's a heart attack. Age is another huge factor, right? 23-year-old with all of these symptoms, that's a different situation. What is melena? Dark tarry stools, right? Not just what you all want to name your daughter one day. Signs of shock is a big one. You're not going to get signs of shock from peptic ulcer. No, I don't think I have any question like this because I think it's a little too tricky, but could somebody get me there? Why would a person be bradycardic and hypotensive who is having a peptic ulcer?
Like vomiting and a lot.
Okay, dehydration. I hadn't thought of that, but sure, maybe hypovolemic shock. That was fast. Good job. That wasn't what I was thinking, but that is true. Actually, the more I think about it, the more answers I come up with. Septic, right? If it got so inflamed and perforated that it became they became septic. Or more to the point, bearing down causes vasovagal stimulation, right? You check a guy, sometimes they don't curve out of it like I think we think they would. You'd think, oh, I squeeze your vagus nerve, your heart rate goes down, I stop squeezing it, right? And the squeeze here is the vomiting, right? Heart rate goes down, then it comes back up because I'm not squeezing anymore. If you're geriatric, you can curve out in minutes. It can take a long time for you to get back to your normal situation. So be careful there. Just a reminder on SIRS criteria, right? Tachycardia, that's heart rates that are greater than 90, not necessarily over 100. That it requires us to have an infection suspicion, not necessarily confirmed, right? What's something that might cause me to suspect an infection? fever, temperature, if I could see redness, swelling, these kind of things, right? I'll never ask you to remember the total leukocyte count, but I just want you to remember that it's on there. What are leukocytes doing in this process?
Fighting off the infection.
Fighting off our infection, so therefore more of them means your body's mobilizing its anti-infection process, right? So be mindful of these things for sure. Also try to remember essentially our progression here, that SIRS criteria is not necessarily sepsis, that sepsis is 2 or more, and then the suspected infection. How do we get into septic shock? If it's hypotension, more to the point, if it's, which means I have to have done what? Given fluids, right? So the test questions are sometimes tricky because I'll write, oh, you guys hypotension, that means septic shock, what should you consider? And that's fine. But I want it to be in your mind as well. It's like, okay, let's give this guy some fluid, because if BP kicks up, then he's all right, we're gonna get through. But every stage of this gets more and more lethal, right? Also be mindful, the colloquialism of sepsis and being septic is just very prolific, you know. People say, well, I'm septic, and they mean septic shock, or this guy's in sepsis, or your organ has become septic, you know, these types of things.
Well, for testing purposes, it's just gonna be either one of them.
I would get framed in your mind. I try to avoid the word septic. Just know that it is very, very common. And sometimes they mean one thing and sometimes they mean the other. More just in the field than testing stuff. Now, what is hepatitis specifically? Liver inflammation. It's not always a virus, because can you get liver inflammation from non-viral situations? You certainly can. What is a non-viral cause of hepatitis? Alcoholism, very good. Another one, it's an over-the-counter medication. Tylenol. I don't know why. Maybe it's your eyebrows. We locked in. I was like, she knows. Non-viral, right? Now, here's my way of remembering a lot of this, or at least my PG version, that hepatitis A is something that you ate, and you usually get that overseas where they're not carefully governing what they put or keep from putting in foods. That hepatitis B and C can be transferred through childbirth, blood, and really any circulating fluids. You won't get questions about E or D, I'm almost sure. Those would be the wrong answers on registry, no doubt. You probably won't get anything on hepatitis A either, but it's easy to remember. If I hadn't said already, I'll definitely be putting these slides up for you, so don't worry too much. Now, hepatitis is often known as a silent infection because as your liver, this big, big organ, just decreases, it can go unnoticed for a long time, your dysfunction. It can lead to jaundice. Do you remember, anybody remember specifically why liver dysfunction is causing jaundice? That's right, the bilirubin. Very good. Ascites, what does that mean? It's not just a Roman soldier. Yep, your fluid buildup in the abdomen. How does it look? Distension. And I ask people all the time, I say, hey, is your abdomen larger? They, oh, I mean I'm fat. I'm like, haha, that's so funny. Seriously though, does it always look like this? Because if it doesn't, that might be fluid, right? Remember that B, hepatitis B, is brief in a sense. At least the fact that it can live outside of the body is briefer than hepatitis C. What I don't mean to say is that your experience with hepatitis B is brief, because that'll last forever. But as far as it lasting outside of the body. Virulence is a term we need to be familiar with. I think honestly, if you're like, I don't know what it means, I just know that B is the most virulent, I'm like, okay, great, love it. It's an equation in a certain sense. It's factoring in how likely it is to contract it, how easy it is to spread, the types of damage it causes. All I mean to say is that, look, hepatitis B may not be the most deadly, but it is the easiest to get. There's a reason that's the one everybody makes you get the vaccine for. But hepatitis C, though less virulent, can kill you. Now, one of the things I've included here is just kind of a quick way to remember which ones we have cures for. It's easy. Cure starts with A. That's the one we got a cure for. Now, hepatitis A and E we don't even treat, you just process them. If you get hepatitis A because you ate a piece of stanky meat, it's going to go into your body, cause all kinds of liver damage, and then your body will process it and it's gone. There's no treatment other than just treating the patient. With hepatitis D, or more to the point, B, that's the one that sticks along for the ride. We don't have a cure for B, though we can treat viral loads and all of these kind of things. What that means is that hepatitis B and D that follows B will stick around for a long time, as long as you do, in fact. We talked in the past about influenza or respiratory viruses, about how basically what a virus does is it takes over one of your cells and starts to make copies of itself, right? HIV does that with your immune system, which makes it very deadly in particular, because now the very thing that's trying to fight the virus is instead reproducing it. That's HIV in a nutshell. Does anybody remember what type of skin or dermatological presentations you can see with HIV? Lesions, yeah. PPE, BSI, scene safety. Pruritic papular eruption, right? You just have to be careful here. Basically, you want to be in the wheelhouse of suspecting this patient might have HIV in the first place, then to see these bumps, kind of not the other way around. Basically, how these questions on tests will get tricky is they'll have you say, oh, this very thin male, and you're starting to get in the wheelhouse like, is this TB that's made him thin? Is it Crohn's that made him thin? Oh, he's got all these lesions and sores all over his body. Okay, Crohn's doesn't do that. Neither does TB. I also put this point on here about the reminder. There's the guy that isolated, I forget, he's a French scientist, but he isolated the virus and found HIV, like the discoverer of it specifically. And there's a video, it's probably still on YouTube, but he's like, look, people are very worried about needle sticks. They should be worried about hepatitis. Hepatitis is super, super contagious. HIV isn't. Like, to the point that CDC will say, if you get stuck with a needle that had HIV in it, your likelihood of getting it is less than 1%. Which isn't enough that you should just go trying it out or anything, but I just mean to take some of the sting out of it. Though every year I say this message, I think, and we're getting farther and farther from the 90s. I don't even think people are overtly scared of it anymore. I'm moving quick here because we're limited on time. If you got to step out or use the bathroom, don't let me keep you up. With meningitis, we're talking about inflammation of the meninges. What are those?
The lining of the spine.
Not just the stuff on top of your lemon pie, right? The lining of the spine and the skull, right? The brain, I should say. It can be viral or bacterial. If you had to choose, which one would you want? Viral, right? The bacterial is far more dangerous and more more likely to cause seizures. Now, as we approach a final, maybe it wasn't too difficult to remember Kernig's and Brodzinski's, essentially, because it was an isolation of the neck stuff. But just know that now it's going to be encompassed with Cares and and Murphy's and a billion other signs because we include abdominal. So try to remember that it's the Kernig's that kicks, because as we move our leg, it instigates pain along our meninges. And at the Brodzinski's that isn't Babinski's involves us bending our head and our knees. Or at least the knees flexing because of the head. What's nuchal pain? What does that mean? Neck pain, which would mean nuchal rigidity. What's a nuchal cord? Right, so nuchal is neck. Photosensitivity, or being sensitive to light. How would you know if a baby had meningitis and was sensitive to light? Well, ask him, right? They turn away from it, you know? You pull a light on your phone and you just kind of edge it towards their face and they're just like super sensitive. You don't have to talk to watch them whinge. Viral is far more common, but it's rarely fatal. Bacterial is more. And the real thing that would get me to think, if a guy was like, oh, I've got neck pain, I'm like, did you fall lately? Uh-oh. And he's like, no. And he's got a fever. I'm like, neck pain, fever? What's your head? My head's all right. I'm like, oh, not great. If he had a seizure, that'll put me in the wheelhouse for bacterial in a hurry. Fatal within days. Wash your hands. That's how we prevent infectious diseases, which I probably shouldn't gloss over that quick. In fact, it is registry targeted information for sure. Wash your hands. Keep your fingies out of your mouth, for sure. Make sure you know these terms, or at least I should say, knowing these terms can be profoundly helpful. We already know unilateral, bilateral, right? That part's easy. Ipsilateral means same side, whereas contralateral will be the other side, the opposite side. My biggest association with seeing ipsilateral largely involves eyes, but I suppose that's a conversation for another day. This is easier to work backwards from. Paraplegia, just think of paraplegia. How does a person with paraplegia get around? Wheelchair, right? Hemi is the other side, right? So hemi is more left to right, whereas para is below or lower or beside. Like, that's why we call them paramedics, right? They're below us. No, they're below or beside a doctor, right? Differentiating plegia and paresis is super important. Plegia is paralysis. Paresis is weakness. It's less than paralysis. If your person has hemiparesis of the face, what am I saying? Weakness on one side. If I said he had hemiplegia, what would that mean? You can't move it. Very good. Remember that paresthesia is that burning and tingling, the pinpricks, the needles, when your hand's coming back to wake from sleep.
You know, something to like see it, you touch it and they winch.
Sure.
Touch that side.
Guys, make sure when we do pupil assessment during our practicals, we are really doing it, right? I know that we're going to see people missing points like crazy. We're like, anyways, how's his pupils? And they're going to say, as you find it. And you're like, okay, so get out your flashlight, get out your pen light, right? Make sure that you're checking these things. I think that you'll be fine so long as you get your light out. That'll probably get you. But if you don't do anything and just ask, they're going to be like, well, you can get away with it sometimes by covering eyes. Like if you don't have a light, you cover their eyes and then remove it so you're subjecting them to what light you have from the ceiling. That'll work. Make sure that we're looking for ipsilateral reaction and contralateral reaction. What does that mean?
Same and opposite.
Same and opposite. Essentially what I'm saying is look, how I always start this process is I look right at my nose and I shine a light in the right eye and look at the left. It should constrict with it. They move in tandem, right? If they don't, you have a disassociation of those things. That means there's a disruption of their optic nerves or maybe how their brain works. That's a big problem, right?
Which one is which one?
Sure. If I said, don't you contradict me, what am I saying? I don't know what that sound was about. But a contradiction is opposite. You're saying something that is opposite, right? Ipsa is the same side. You guys know, like Ypsilanti from Michigan? No, that's not. Do you? Oh, have we had this conversation already? That's right. There you go. We'll be fine. Screw these guys. Bunch of southern monkeys. Okay. So with pupils, make sure that you know literal definitions of these things. That meiosis is, in fact, the constriction. It means less than 2. If you're looking at pen lights, the amount of times I've seen people be like, whew, looks pretty constricted to me. I'm like, it's a 3. That's not constricted. That just looks small. There's not a whole lot that causes pupillary changes, so if you can memorize these things, it'll get you through a lot. Organophosphates, cholinergic, anticholinergic. Ooh. Make you leak to death. We need to make sure that we can differentiate specifically multiple sclerosis and Guillain-Barré. Let me see, what do we got, 15? Let's do it like this for now. They are both demyelination of the nerves, right? Your nerve cells, like we have red blood cells, right, called erythrocytes. They carry hemoglobin. We have neurocytes, which work like links on a chain or a wire for communicating electrical activity and communication through neurotransmitters. If a wire isn't surrounded by insulation, then it can be less effective and more prone to danger. The signal will escape it. Myelin is essentially the encasing of the neurons. So both Guillain-Barré and MS are degradation of myelins. It's just that one involves your central nervous system and the other is your peripheral nervous system. In part, I think that if I were to say, if you said, hey, can you make this even simpler? I'd say, sure, no problem. Central nervous system, peripheral nervous system. That with Guillain-Barré, people aren't usually dying from it unless you can't ventilate them. And that it usually follows immunization. Guy goes in for a flu shot, next couple of days, he stops breathing. Why? Guillain-Barré. Why would a person who has a peripheral nerve, which involves your arms, legs, and so forth, why would he stop breathing? Well, what nerve is associated with your breathing? The phrenic nerve. The phrenic nerve is a peripheral nerve. So Guillain-Barré is recoverable. These people get better usually just fine once the inflammation has stopped, right? However, we need to be mindful because they may also go into respiratory failure as their peripheral nerves are affected. But the big thing here is getting flu shots. That's where the only time I've ever seen it. They just have an overreactivity. Now with MS, essentially, we've got brain and spinal cord issues. These are far and away more associated with women. Yo.
Can you have both? Are they like...
Probably. But what it would be is you were born with multiple sclerosis, then you are the tragic individual that got a flu shot, that your system also overreacted to that. But Guillain-Barré is essentially more like getting the flu than it is a disease you get and can't quit.
So it's recoverable?
Yeah. And like, as long as they don't stop breathing, it's uncomfortable, but very recoverable. It's just that little part of the not breathing thing can hit pretty hard. One of the things I want to mention too about multiple sclerosis is specifically trigeminal nerve issues. I said before, this trigeminal nerve is this three-pronged nerve, this cranial nerve that goes across the face. It's not that it's a peripheral nerve specifically, but it works like one. Trigeminal neuralgia is maybe the most pain a human being can experience. When you have an issue in your trigeminal nerve, people commit suicide because of it. It is the most pain a human can experience, pretty universally. Well, MS can cause it. I don't know what else would be the problem, probably other inflammatory and systemic issues, but trigeminal neuralgia is perhaps the most pain a human can experience. It'll make them run into traffic to stop it. Another thing that might help you get through Guillain-Barré versus MS is visual issues, because the optic nerve is also affected by multiple sclerosis, so these people have vision issues. Let me take a look here. Yeah, I think we'll take a quick break now that he's back, and then, all right. Lou Gehrig's disease, also known as advanced life support. Amyotrophic lateral sclerosis, or ALS is I guess the joke I'm making. It's what Lou Gehrig had, but I don't watch a lot of basketball. Mostly I remember that this fella's got it, right? Mr. Stephen Hawking. Now, ALS is a progressive degeneration of our motor neurons, which, if you think about it, your motor neurons are very important for movement other than your legs and the like your breathing. We know it has a genetic component, but we're not exactly sure yet what causes it. Maybe if somebody that was really smart got it, then we would know. Lou Gehrig's essentially, like I said, progressive weakness. It has spasticity. What does that mean, spasticity? Spasms, yeah. What about dysphagia? Difficulty swallowing, right? If your motor neurons of your throat and the muscles involved with your tongue aren't working very well, you can have trouble swallowing, no doubt. Muscular dystrophy is often confused with MS in testing world. MS and MD, very different things. Muscular dystrophy, usually when we refer to it, we're talking about Duchenne's, not that you need to make that distinction. I just, in A&P, learned that there were a whole bunch. I didn't know that. Basically, your muscles pull themselves apart. Muscular dystrophy is largely associated with boys, though girls can get it too, just more likely with boys. Don't remember why. Oh, I don't know that I ever knew why. Basically, as our muscles tear, they rebuild themselves to get stronger. If you have muscular dystrophy, it doesn't make that repair, which means every time you tear your muscle, it stays that way. And they die largely due to respiratory failure because their diaphragm's a muscle, and as it pulls and tears, it doesn't repair itself. Surprising perhaps nobody, you get muscle failure as well as paresthesia. What's paresthesia again? Tingling, right? Numbness, tingling, burning, that kind of thing. Abnormal sensation. You can get muscle stiffness and weakness as it breaks down and becomes immobile. Their life expectancy is very low. You're not necessarily walking up to a scene and then being like, whoa, you think this is muscular dystrophy? No, you come up, they know what it is, right? It's been affecting them since birth. This is a summary slide. You're going to want to be able to kind of make some distinctions on the language here. Hopefully anemia is easy, right? Low red blood cells are in some cases specifically relating to the hemoglobin. Poly meaning many. I tried to color code them associated with the type of cell they are associated with. Anemia and polycythemia are both red blood cell issues. Leuco for the white blood cell. Thrombo for the platelets, right? Therefore also found in thrombophilia. Philia means to love or to like, I think. So it's got an affinity for it, which means thrombophilia like hemophilia. So we've got two things I think we're familiar with on either end of this chart that'll help us work backwards into it, or at least internally. Now, I don't know how many questions I have on this. I don't plan on writing any, but I would be a little surprised if one or two weren't in there, and it's definitely going to be, it might be anemia or hemophilia, but they're words I want you somewhat familiar with because they might be keys in other questions that help you through it. If I said your patient is tachycardic tachypnea and has swelling with leukopenia, do I think SIRS? The answer to the question is way harder because you could say yes and no in both cases, but that's kind of what I mean, is using it to kind of work through some stuff. Now, with disseminated intravascular, syndrome? Something like that? DIC, right? Essentially, sepsis can cause this, but really any major trauma insult. Basically, it's a condition that happens when your body is clotting unnecessarily or incredibly so in a million different reasons, or different ways, different areas, goodness. And so therefore, when you bleed, you can't clot. So most people, I think, mean that DIC, or think that DIC is just too much clotting, but it's both at the same time. You clot where you maybe don't need to, or you simply clot too much. And so that way, when you start bleeding, you can't clot because you've been clotting elsewhere way too much. Remember that sickle cell is the misshapen hemoglobin, which then misshapes your erythrocytes. What do we as AEMTs, what's our treatment path for people who are experiencing an acute issue with sickle cell? Pain management. O2, because we want to load up anything that can, right? What else? Sickle cell hospital for sure, which last I knew Grady was. We're missing one thing, fluid. Volume support essentially isn't what we're looking for here. We're just trying to either A, lubricate these very clingy cells, or help kind of move things along so they're not binding up so much. So oxygen, pain management, fluid, transport. Yep.
Like, are you just doing like the 20 per kg?
Yep. It doesn't super matter. I would probably run a bunch wide open because in my opinion, every human in America is dehydrated. So if I get to the hospital and I dropped 1.5 liters in you, I'm like, you're welcome, sorry about the pee, you know. But they're definitely gonna do that at the hospital.
I didn't know if there was like a specific
Concern or, nope. Nope. If they were bleeding, that's different. Know that cystic fibrosis is a genetic disorder. I think I learned last year it's not just primarily affecting girls, so if I said that to this cohort, oopsie doops. It affects a bunch of different people. The most important thing is to know, outside of it being a genetic disorder, that it's an issue with the genes involved in your mucus production, meaning you produce too much in your lungs, in your digestive tract, and they also in their sweat glands, which leaves them with very sweaty skin because they can't excrete appropriately. Salty skin, I should say. But most of these people are essentially, if not dying due to the fact that they can't process the food they're eating because their pancreas is shutting down, a lot of times it's airway issues. If they have a bunch of mucus in their lungs, they've got too much liquid where it doesn't belong, and liquids collect solids, which is why these guys get pneumonia and respiratory infections like crazy, because their lungs are always full of mucus. And they'll wear those little vests that kind of tremor and shake so that way they can break up the mucus and get it out. There you go. Diseases.